Thank you everyone for joining us and welcome to the Cancer Research Institute's webinar series, Breakthroughs in Cancer Immunotherapy. Today's date is Friday, August 21st, 2015. The title for today's webinar is Immunotherapy for Lung Cancer, What Patients Need to Know. In this webinar, we will discuss current immunotherapy treatment options for patients with lung cancer, and we'll touch on important things patients should think about when considering immunotherapy. Before we begin today's webinar, I'd like to thank our generous sponsor, Regeneron. It's made possible with their generous support. Regeneron is a leading science-based biopharmaceutical company that discovers, invents, develops, manufactures, and commercializes medicines for the treatment of serious medical conditions. For additional information about the company, visit www.regeneron.com. My name is Brian Brewer, and I'm Director of Marketing and Communications at the Cancer Research Institute. Cancer Research Institute is the world's only nonprofit organization dedicated exclusively to funding science that teaches us to harness the immune system's power to conquer all types of cancer. We fund scientists around the world whose work has led to significant breakthroughs in treating cancer with immunotherapy, also known as immuno-oncology. Over the next 45 minutes, you'll have an opportunity to hear from an immunotherapy expert how cancer treatment today is undergoing a revolution thanks to these breakthroughs. After a 25-minute presentation from our speaker, we'll open the room to questions submitted by you. You can pose your questions at any time throughout the webinar by typing in the Q&A box on your screen. You can also tweet your questions to us at Cancer Research on Twitter, but be sure to please use the hashtag CRIWebinar. Now it's my pleasure to welcome today's expert speaker. Dr. Julie Brahmer is the Associate Professor of Oncology and Director of the Thoracic Oncology Program at the Sidney Kimmel Cancer Center at Johns Hopkins University. Dr. Brahmer's research and clinical practice focus on the development of new therapies for the treatment and prevention of lung cancer and mesothelioma. She is certified in medical oncology from the American Board of Internal Medicine, and we're very grateful that she could take time out of her day to join us today. Welcome, Dr. Brahmer.
Well, thank you very much, and thanks for everyone for joining us today to discuss some of the exciting changes in lung cancer therapy. And certainly we're going to focus on non-small cell lung cancer today, but certainly some of this immunotherapy treatments also are being looked at in patients with mesothelioma as well as small cell lung cancer as well. And hopefully over the next several months, you'll be hearing more about this. Soon in September, our World Congress on Lung Cancer will be going on here in the United States, and we hope to be able to report on new developments in the current research ongoing. But to get started for today, what I thought I would talk about is first some basics about your immune system and how the immune system actually looks for cancer and helps try to control cancer, but certainly how cancer itself can use the body's immune system and shield itself from its immune system to be able to continue to grow and metastasize. And then we'll talk specifically about some of the drugs that are being developed and now approved for the treatment of lung cancer. So, and I am an oncologist who has a specific interest in lung cancer, and I've been interested in lung cancer from the time that I started my fellowship. And then throughout my career, I've been interested in drug development, and over the past 6 years, I've been working with immunotherapy agents in the clinic on clinical trials. So let's get started with the meat of the discussion. So your immune system is made up of various different organs. Certainly we have lymph nodes, your tonsils, your thymus gland, spleen is part of your immune system, as well as your bone marrow that makes the white blood cells that are part of your immune system. So, and the cells that make up the immune system are made up of your white blood cells, the B cells, macrophages, neutrophils, eosinophils, and basophils. So when you look at your CBC with differential. If you look at the differential of the white blood cells, you'll see listed these various different types of cells and percentages and numbers of these cells in your peripheral blood. What the type of cell that we think is particularly important in controlling cancer in your immune system is the lymphocytes, particularly the T lymphocytes. These lymphocytes are those that go to the tumor and try to attack the tumor. Certainly the natural killer cell, as you can see here on the right, can play a role in helping to control cancer. The T lymphocyte is extremely important, and what most of the drugs that we're developing these days that will target. Certainly macrophages are important as well, and certainly there's drugs being developed to target these types of white blood cells as well. But we'll spend most of our time talking about the lymphocyte and the key role that it plays in controlling cancer. So your immune system has two arms. One is called the innate immune system, and this is your body's first line of defense, and it includes four main types of defensive barriers. So that's your skin, a physical barrier, which is part of your immune system, as well as a phagocytic barrier and inflammatory barrier. Now the adaptive immune system, and again we'll be focusing on this part of your immune system, this comprises of the lymphocytes that I was talking about before, and then something called antigen presenting cells, and I'll talk about this specialized cell in just a bit. This is particularly important both in the therapies that we use, the antibodies that we use, as well as vaccines that we'll briefly talk about today. Now the adaptive immune system, the most important cells in the adaptive immune system are the lymphocytes. So you have a cytotoxic T cell. This is the type of T cell that kills virus-infected and damaged cells. So this is the particular cell that we think is important in controlling cancer. There are also helper T cells. These are the cytotoxic T cells that help these T cells stay active, as well as your B cells stay active and work effectively in their immune function. B cells are also important and produce antibodies to protect your body from foreign invaders such as bacteria. So this is how we think things work within your tumor. So that as the tumor cells grow and die, they secrete something called a tumor antigen. This antigen is basically a protein. The protein is taken up by the dendritic cell, or what we call the antigen presenting cell, and processed. And in order for your body to recognize that protein, that dendritic cell has to process the protein, use the arrow here, and then present it on its cell surface and present that protein to the T cell. That protein binds to a T cell receptor, and then the goal is to activate the T cell. In order to actually activate it, another signal has to occur here from the dendritic cell to the T cell, and this is a stimulatory or activating signal. Both binding of the receptor to the protein, and then this signal is needed for the T cell to become activated and then seek out the tumor, secrete killer enzymes in order to destroy the tumor. During this time, that T cell also divides and grows into what we call T cell expansion, so that those T cells can continue to divide and then find tumor and kill it. The problem is, as I'll show in a bit, that there are various different pathways that control a T cell activity as well as control the T cell. So it really does take a village to control a T cell. There are signals it requires to activate it, these green arrows, but there's also signals that are used to actually control the T cell or actually cause it to be deactivated. Typically, our body uses this deactivation pathway to prevent autoimmune diseases or out of control immune reactions. But we know that cancer can co-opt these type of pathways and use it to its advantage to itself shut down T cell function. So we're finding more and more about this, but the one pathway that we know most about is something called CTLA4, which is an inhibitory pathway, and PD-1. Certainly this is a very simplified schematic. There's at least 15 different pathways, either stimulatory or inhibitory, that are being discovered, and then that may play a role in controlling a T cell response. So the stimulatory pathways are basically the gas to the immune system. The checkpoint pathways are the inhibitory pathway and basically are the brakes of our immune system. So there's always a fine balance between the brakes as well as the gas in the immune system. You want a fine balance typically in your body, but when you have cancer or you have an infection, you want a stimulatory signal, but do not want an inhibitory signal. So let's change gears a little bit and talk about various different therapies that we have to be able to harness the immune system. So I'll spend a brief period on vaccines. Right now in lung cancer, vaccines are being tested, but nothing has been approved yet compared to the vaccine for prostate cancer and melanoma. And certainly now we'll spend most of the time talking about immune checkpoints. So cancer vaccines, there's various different types of vaccines that are being looked at, either taking a cancer protein or otherwise known as a peptide like we were talking about before. Sometimes these vaccines are whole cell vaccines where they take someone's tumor cells and use that in the vaccine, and they combine it with something called an adjuvant. When giving the into the skin of a patient, antigen that the vaccine has, either protein or peptide, is taken up by the dendritic cell or antigen presenting cell. The adjuvant is supposed to activate that cell and then allow it to express these different proteins on the cell surface, attract T cells to recognize that these peptides are abnormal, activate them so they can go after a tumor cell. And as you can see here, there's various different vaccines that have been in development. This is not the whole list. Certainly over time, the vaccine technology continues to rapidly improve. And certainly like Provenge for prostate cancer, and then some of the newer vaccines that also incorporate either viruses or bacteria that are attenuated are being developed. But these are some of the trials that have been done in lung cancer. The MAGE-A3 is a protein that is expressed in some lung cancer. This vaccine was looked at after surgery. Unfortunately, in a large trial, it did not show a survival advantage. There's another vaccine called the BLP25. I can't even pronounce it. That's why I abbreviated it. But this vaccine was given after chemotherapy and radiation therapy for patients with stage 3 disease. In general, it did not show a survival advantage, but there's another trial that is ongoing to look at the subset of patients who did have a survival advantage, and those were those patients who received chemotherapy and radiation at the same time and then received this vaccine. So there's another trial ongoing, and so this vaccine is still being evaluated. The Luconix vaccine, this was given after chemotherapy in patients with metastatic disease, in this trial did not show a survival advantage. There's the Cuban vaccine that is being evaluated now in the United States that is directed towards the EGF ligand or epidermal growth factor. And this is being looked at in advanced disease, and there's a trial that's ongoing here. And then there's another vaccine called TG4010. This is being evaluated in patients with metastatic disease as well. So vaccines are not dead. And again, like I said, the technology of the vaccines are making great strides compared to some of these original trials as well. So let's start with the checkpoint inhibitors. That's certainly where the biggest excitement has been. And certainly melanoma is a disease where a lot of this got started, and lo and behold, we have seen activity in lung cancer. But let's start with the first antibody that was approved for any cancer, and this is ipilimumab. And this antibody, which is given by vein, blocks the checkpoint pathway called CTLA4, and that is this pathway here. So by blocking this inhibitory pathway, this allows the stimulatory signal to continue to be sent towards that T cell and the T cell to remain activated so that it then can go on and to kill the cancer. So, and certainly ipilimumab has evidence of activity in a broad range of cancers, mainly melanoma, and that's where this antibody is approved. In patients with melanoma, they have seen responses in those patients with brain metastases as well, and it is being looked at in various different tumors here, all the way from prostate cancer, lung cancer, kidney cancer, and pancreas, and Hodgkin's lymphoma or non-Hodgkin's lymphoma and other tumors. In general, ipilimumab is moderately easy to tolerate, but it does seem to cause more immune side effects compared to the other checkpoint pathway inhibitors that we'll talk about next. But those common side effects are skin rash, diarrhea, some endocrine dysfunction, and then effects on the liver. It is being studied in lung cancer. This is a large trial looking at combining the ipilimumab with chemotherapy in squamous cell lung cancer. This trial has been completed, and we're still awaiting the results. We hope to see these results within the next year. It is also being looked at in small cell lung cancer as well, in combining with the standard chemotherapy for patients with small cell lung cancer. So again, the most excitement and press for lung cancer has been with the PD-1 pathway checkpoint. So this is something called a programmed death 1 pathway. It is, again, important in controlling the T cell. So here's your antigen presenting cell over here in yellow, giving that antigen signal to the T cell receptor. You've got the stimulatory signal coming in, causing the T cell to be activated up here and divide and basically recruit an army of T cells. And then it expresses something called PD-1 on the receptor surface of the T cell. It binds to a ligand that either your normal tissues can express, but also the tumor cell can express. And then by binding that causes the T cells to go off, be exhausted, and then those T cells die. Now, by blocking this pathway with an antibody, then this allows the T cells, instead of going off and being exhausted, they remain activated so that they can attack the tumor. We basically describe this PD-1 and PD-L1 interaction by the tumor of trying to put a shield up and basically prevent the immune system from attacking the tumor. But by blocking that shield, then your T cells remain activated and are able to recognize the tumor and kill it. There's various different ways that we can block this pathway. One is by an anti-PD-1 antibody. So these antibodies are developed to block this pathway by blocking the receptor on the T cell. And this binds or prevents the binding of the PD-1 to its two ligands. It has two ligands that target cells or tumor cells can express. Now, you can also block the pathway by using an anti-PDL1 antibody. So blocking the pathway by developing an antibody to bind to the ligand, but not the receptor. No one knows which type of antibody is better. There's some theories to say that maybe the PDL1 antibody is less toxic by just binding to the ligand rather than the receptor, but none of these antibodies have been compared head-to-head, and in general, both antibodies can have side effects. So let's step back again. So we know what the immune system is and what different pathways your immune system uses to control itself, and how tumors can use these pathways to be able to put up a shield and prevent the immune system from recognizing it. Certainly vaccines have been developed to try to stimulate the immune system, but certainly, again, I think the tumors have figured out to be able to shut down those T cells that the vaccines are trying to develop and direct, and the T cells go into the tumor milieu and are unable to do their job, and so that's where the checkpoint pathway blocking agents come in. Now, in lung cancer in the past, it was felt that immunotherapy really did not play a role in how lung cancer develops, but I think we're learning more and more. And certainly there's more and more new types of therapies being developed, not just immunotherapy. Certainly this is, as you all know, with yourselves as well as your loved ones, lung cancer is a very common problem. This is the second most common cancer diagnosed in both men and women. And unfortunately, it is one of the deadliest cancers here in the United States. However, there are a lot of survivors with lung cancer, and we hope with smoking cessation, CT screening, and some of these new therapies that the number of survivors will continue to increase over a short period of time. And certainly it's not quick enough in a lot of our minds, but we continue to strive to improve the number of people who are surviving this disease or living with this disease. So an average patient who comes in with lung cancer is typically elderly. I'm sorry for those people who are in their 70s. Typically the average age is 70, though some people would say the 70s are the new 60s. Certainly 2 out of 3 people who are diagnosed with lung cancer are 65 years of age or older, and less than 2% of all cases diagnosed are in those younger patients, though it seems like in my clinic and as well as in other clinics, we seem to be seeing younger people, but in my mind, maybe it's the fact that I'm getting older and seeing more younger patients. But we do see younger patients, but that is not very common. Most of our patients have previous or current smokers. This number of previous smokers continues to increase as people stop smoking, but certainly at least 15 to 20% of those patients who are diagnosed do not have a smoking history. And certainly they're either exposed, secondhand smoking, or other environmental factors can have effect. Certainly, some people say radon is the second most common cause of lung cancer, and there's other environmental causes as well that can be associated with occupational exposures. The treatment options have come a long way over the past decade. Certainly, like I said before, not quick enough, but certainly we are making strides. To just give you an example, Life was easy for those of us who originally studied lung cancer. When you take your boards back in the early 2000s, it was there weren't that many choices when it came to answering a question on our internal medicine boards. Your options for treatment for patients with metastatic non-small cell lung cancer were chemotherapy combination. That hasn't changed that much over the past decade. But the second line treatment option was docetaxel. And then back then, gefitinib was just approved for use in patients with lung cancer. And this is a epidermal growth factor receptor oral inhibitor that is now reapproved this past year for patients with EGFR mutated disease. But now, over the past decade, we believe that a driver of improved outcomes for patients is really a better understanding of the disease. As your physicians probably have talked with you, we decide on what type of therapy you should get when you have non-small cell lung cancer on first what type of histology that you have. So adenocarcinoma, squamous cell carcinoma, large cell carcinoma, and then also, like I said, small cell lung cancer is treated completely differently. And over the past decade, molecular classification of lung cancer really has taken off. Various different mutations have been described over the past decade, and different therapies have been developed to target these pathways, particularly the EGFR pathway with erlotinib, afatinib, and now gefitinib is reapproved. The ALK pathway, multiple different drugs are being designed to block this pathway, and we have crizotinib and ceritinib right now approved, and we hope to have other drugs approved for this pathway. Certainly hot on all their heels is the various other pathways, and ROS1 was recently described over the past 5 years, and crizotinib is being used in patients with this type of abnormality. But certainly this list continues to grow longer. Over the past 6 months, something called an NTRK abnormality has been described as well. So now in 2015, I'll go through how that easy algorithm is much more complicated, and we think has been driving better outcomes for patients. So if you're diagnosed with metastatic non-small cell lung cancer and you have squamous cell histology, first line treatment right now standardly is a platinum-containing doublet, either a taxane, either a Abraxane, paclitaxel, or gemcitabine, combined with either carboplatin and cisplatin. Second line and beyond, just newly approved for use is nivolumab, which we'll get into. That's an anti-PD-1 antibody. Or if patients can't receive immunotherapy, then the standard chemotherapy of either docetaxel plus a new antibody called ramucirumab, or navalbine, or one of the drugs you did not use up in the first line treatment setting. Now, if you have non-squamous cell histology, genotyping is important, since typically the EGFR antibody and the the EGFR mutation or the ALK translocation are just mainly seen in non-squamous cell patients. And if you have one of these abnormalities or ROS1, then a targeted tyrosine kinase inhibitor or pill is the treatment of choice. If that stops working, then depending on the mechanism of resistance, then we can use another therapy such as ceritinib in those patients with ALK positive disease, or chemotherapy can be used at any time as well. Now, if you do not have one of these abnormalities, then right now the first line treatment choice is a platinum doublet with either carboplatin and cisplatin, with either pemetrexed, otherwise known as Alinta, or paclitaxel. Also, bevacizumab can be combined with chemotherapy up front, and then the concept of maintenance therapy is used for patients with non-squamous cell histology. Certainly in the second line treatment setting and beyond, Nivolumab does have compendia listing. It is not yet FDA approved in this setting, though. Also, other chemotherapies can be used, including the docetaxel plus ramucirumab, pemetrexed if you did not use it up front, or other types of chemotherapy. So certainly this looks a bit more complicated than what we had before. Now, once nivolumab was approved for use for squamous cell lung cancer, continued excitement is being seen in the development of the PD-1 checkpoint pathway inhibitors in non-small cell lung cancer. And like I said, it is being studied in small cell lung cancer, and these antibodies are also being studied in mesothelioma patients as well. Nivolumab was the first antibody approved for use for non-small cell lung cancer, but hot on its heels is pembrolizumab, which we hope is approved by the end of the year for non-small cell lung cancer. This too is a PD-1 antibody. Remember those antibodies that block the receptor on the T cell? But there's multiple PD-L1 antibodies in development, and these antibodies block the ligand on the tumor cell to prevent its binding to the T cell receptor. There's a drug called durvalumab that is in phase 3 trials, atezolizumab, which is also in phase 3 trials, and certainly the farthest along in lung cancer development of all the other PD-L1 antibodies. This is not an exhaustive list. There are multiple other PD-1 and PD-L1 antibodies out there in development, but those studies are much earlier in their development, either in phase 1 or phase 2 trials. So I think from the phase 3 trials that have been, you may have heard about in the press or heard from ASCO presentations this year at the large cancer meeting in Chicago in June, the biggest data for lung cancer was that nivolumab, the anti-PD-1 antibody, was shown to improve how patients do compared to those patients who received docetaxel for both patients with squamous cell lung cancer and non-squamous cell lung cancer. So patients live longer when they receive nivolumab, and the response rates, the tumor shrinkage rates, were higher. The response rates are about 20%. And this is about double what you would expect from docetaxel by itself. But this does not include those patients whose disease was controlled as well, or stable. So if these antibodies keep the cancer stable for a longer period of time, that's very exciting. Certainly the stabilization rates and the responses tend to last longer than what we would expect with chemotherapy. Typically with chemotherapy, the chemotherapy on average keeps someone's cancer under control for about 6 months, but for nivolumab or drugs like it, if it works, it tends to work for a long time, typically over a year. In general, this type of antibody, or nivolumab, showed less side effects compared to the docetaxel or chemotherapy. There's less intense side effects, but these side effects tend to be completely different than chemotherapy. And then these phase 3 trials led to the approval of nivolumab in squamous cell lung cancer by the FDA. And so this is for the first time immunotherapy has shown activity in lung cancer and beaten chemotherapy. And this is for patients who had first been on the platinum-containing chemotherapy for their first type of treatment, and then on this trial in what we call the second-line setting. So this is just an example of what you would see on a CAT scan. This was a patient whose cancer had progressed on chemotherapy and bevacizumab. They were treated with nivolumab. The standard dose for nivolumab is 3 milligrams, and it's per kilogram, so it's based on your weight, how much antibody you get. This was, you're looking at a CAT scan, so this is a liver, kidney. That's where the top of the other kidney is, and this is a spleen on this side, and then this was the adrenal gland mass. So this is cancer in the adrenal glands. After 3 months, this was the adrenal gland mass that had significantly decreased in size. So this is just an example of this is not chemotherapy, this is the immune therapy. This is an example of someone's lung. So this would be the right lung and the left lung, and this is the middle of the chest called the mediastinum. And this is the cancer here in one section of the CAT scan, and then lower down, this is evidence of the other areas of cancer. So this person was on the nivolumab antibody, and the first scan that was done while they were being treated made it look like their tumor was actually bigger, as you can see here. So if you got that type of report, if you read that on your my chart, you'd be pretty alarmed in the fact that, hey, maybe your cancer is getting worse. But actually, in a small subset of patients, your tumors can actually look worse on the CAT scan. And then if patients can feel well, they can remain on this type of therapy, and the nivolumab and other PD-1 or PD-L1 antibodies can actually take a while for it to work. And you can see here, 4 months down the road, their tumor actually has shrank, as you can see here. So this is something that we call pseudo progression. What we think happens is that when you start on these antibodies, your T cells are so stimulated, they go to the areas of cancer, they make it look like the tumor is bigger, but then actually it's really the T cells at work, and then actually as they kill and remove tumor, you can see down the road the cancer actually shrinks down. Now again, this only happens in a small subset of patients, but if you're feeling well, your oncologist will recommend that you stay on treatment for another set of scans to see whether or not is your cancer truly getting worse, or does it really get better over time. So I guess I hope I'm explaining this well enough to just say, if you're doing well on the antibody and you're tolerating it and feeling well, you have to be able to take a step back and take a deep breath and continue on treatment and give it another usually 6 to 8 weeks to see whether or not it responds. Now, if you get a scan like this and you're not feeling well and you're having a lot of either side effects or symptoms from your cancer, we typically would recommend that we move on to the next type of treatment, and the likelihood of this going to this would be quite low if you're not doing well from a side effect standpoint. So what about side effects? Certainly we like to get away from the side effects of chemotherapy, and we'd love a drug that doesn't have any side effects, but unfortunately any drug that we give can have side effects. But in general, my patients say that the immune side effects that they can get from these type of antibodies is relatively minor compared to what they experienced with chemotherapy in the past. But fatigue is the most common side effect. Certainly rash can be seen, but typically these are well controlled with some topical treatments such as topical steroids. Diarrhea, or something called colitis, can be caused, and when this happens, you definitely need to talk with your physician about this so that they can evaluate you and make sure you don't have an infection, or if it's a diarrhea caused by the immune treatment. We usually initiate steroids early and we taper them very slowly so that the colitis or inflammation does not actually rebound or get worse. This type of immune therapy can affect your liver, called hepatitis. You can get allergic reactions or infusion reactions with these drugs, and then these antibodies can actually direct the T cells to your certain glands. A lot of patients can have low thyroid levels because of these antibodies, or high thyroid levels. Your adrenal glands may not work, or your pituitary glands may stop working because of these antibodies. These side effects, the adrenal and pituitary side effects, are not very common, but the thyroid, low or high thyroid levels, we see probably most often. Infrequently, and something that we are always concerned about in patients with lung cancer, is lung inflammation or pneumonitis. This is not very common, but it's something that we monitor on scans, and that's why we ask you about whether or not you're more short of breath, and why we monitor the oxygen levels in when you're at rest and walking more often when you're on this type of therapy. But in general, severe toxicities are uncommon, and not very often do you need to be on medicines to control these reactions. Just to give you an idea from a pneumonitis or inflammation of the lungs standpoint, this is the rate that this occurs and requires steroids with the PD-1 antibodies about 2% of the time. But this can also occur in patients being treated with erlotinib or Tarceva, gefitinib, now also called Iressa, docetaxel and gemcitabine, and pemetrexed can also cause pneumonitis as well. Certainly, those of you who have had radiation to the lung, you can develop pneumonitis, and again, that rate is much higher compared to these antibodies or chemotherapies. The treatment for pneumonitis or inflammation of the lungs is steroids like prednisone. So I just wanted to briefly touch about PD-L1 testing. So everyone wants to have a biomarker. How can we pick which patients will do well with the immune therapy or nivolumab or pembrolizumab or other therapies? Is there something about the tumor that we can check to see who should receive this therapy versus others who should not? Right now, people are excited about something called PD-L1, again, the ligand to PD-1. And we know that about 50% of patients with lung cancer can express this ligand on their tumors. We think the PD-1 or PD-L1 expression can influence the chance of responding to this type of therapy. However, in the phase 3 trial of nivolumab in squamous cell lung cancer patients, we went back and looked at the PD-L1 testing or staining on their tumors. And the staining, whether it was positive or negative, did not influence the outcome. So it didn't matter whether or not your cancer expressed PD-L1 on that test or not. You did well if you had squamous cell lung cancer. Now, this was different in those patients with non-squamous cell lung cancer. In that trial with nivolumab, PD-L1 expression on your tumor cell did seem to influence the outcome. At least it seemed to influence that if your tumor expressed PD-L1, if you were on nivolumab, you did much better compared to those patients who were treated with docetaxel. Now, if your tumor did not express PD-L1, you did as well if you received nivolumab or docetaxel. So it was a little bit different if you were on the non-squamous cell trial and had non-squamous cell lung cancer versus the trial that only allowed patients with squamous cell cancer. So it's confusing. We don't know if you need to have PD-L1 expression yet. Certainly, we're awaiting other trial results to see if there is some type of consistency in these results to better advise people about whether or not their tumor should be tested. Most of the clinical trials out there are looking at this as a potential biomarker, but it's certainly not ready for prime time yet, because there's multiple different questions regarding the PD-L1 testing. And actually, I sat down in front of a patient the other day. It's like, well, why can't I just go ahead and get my tumor tested? If it was PD-L1 positive, then I'll want to do immunotherapy, and if it's negative, it's not. The problem is right now, you can send your tumor out for testing at a facility, but we don't know how good is that test. Are these the tests being used on the clinical trial? Most of those tests are not yet approved to use outside of a clinical trial. And then those that are being used, how good is that test? And are we testing the right cells? There's certainly differing commercially available antibodies. Again, like I said, most of the available antibodies that were used on the clinical trials are not being used in the clinic and not available in the clinic. And also, we don't know what is important, tumor staining or surrounding tissue or both. We also question, what about how old of a biopsy is too old? Could we just use somebody's surgical resection that was done 3 years ago, or do we need a fresh biopsy when they're first diagnosed with metastatic lung cancer? And that the answer to that question is not out yet. What about the differences in expression within tumor tissue? Did we biopsy the right spot? So if your tumor biopsy is negative from one area, could it be positive in other areas if we biopsy those areas? And we think that's potentially true. So, you know, that is a big question. And then also, is the presence and composition of a tumor, the lymphocytes within the tumor, is that required to have PD-L1 positivity? And again, those answers just aren't out there yet. Certainly, there's a ton of other trials ongoing in the first-line treatment setting. So is there a group of patients who never need to see chemotherapy? Certainly, many of you may be on these type of trials looking at these different antibodies compared to chemotherapy. Most of these trials are looking at using their own antibodies to stain for PD-L1 in the tumor tissue. There's certainly other second-line treatment trials ongoing. This is pembrolizumab as well as atezolizumab, and there's multiple trials ongoing for those patients who haven't received immunotherapy in the second-line treatment setting. But what about the future? So response rates of 20% are awesome. They're great, but we want better. So can we combine different antibodies to unleash the immune system against your tumor? Should we be combining with chemotherapy? We're not sure. Is chemotherapy good and can kill off cells that we know can influence the immune system? Or is it bad and affect our immune system so it can't be strong enough to react to these antibodies? Should we combine it with radiation? Should we resurrect some of the cancer vaccines and combine it with these PD-1 antibodies? And then at Johns Hopkins, we're looking at whether or not we can use different therapies to prime your immune system as well as the tumor to better respond to the PD-1 pathway inhibitors. So I'd just like to close to say that immunotherapy agents have promising anti-tumor activity in lung cancer, non-small cell, small cell, as well as mesothelioma. These agents, though, have a unique set of side effects that are consistent with how the immune system works, and certainly it's completely different from chemotherapy, and certainly we have to take a time to make sure and educate you about what side effects to expect. Certainly, patient selection or biomarkers will be the key to future development of these types of therapies, but we're not quite ready to use them for prime time. So now immunotherapy is a reality for the treatment of non-small cell lung cancer. But again, like I said just before, we need to do a lot more in developing immunotherapy for each person and try to individualize this therapy either in combination or in single agent and try to figure out how best to help all of you with lung cancer. So next, I'd like to open it up to questions.
Great. Thank you so much, Dr. Brahmer. That was a very comprehensive overview of the exciting developments happening in lung cancer with immunotherapy. So I'd like to just remind everyone that you can ask questions of Dr. Brahmer by typing in the Q&A box on your screen. We hope to get to as many questions as we can, although we are starting to run short on time. So I'll start with an interesting question. It's about the role of mutations in the effectiveness of immunotherapy, and in particular the role smoking can play in causing multiple mutations. And there are some studies or indications that lung cancers that arise in people who smoke or previously smoked may be more prone to immune control after treatment with immunotherapy. Have you seen anything like that, or can you talk a little bit more about that?
Yes, so in the clinical trials, particularly with non-squamous cell histology patients, we saw that patients who were former smokers or current smokers, their cancers were more likely to be controlled than those patients who had never smoked. And we do think the theory behind that is that patients who have smoked or been exposed to smoke have more mutations causing abnormal proteins or peptides that your immune system can recognize as being abnormal compared to those patients who are never smokers. Now, we just have to be better at figuring out how to harness the immune system in never smokers. So we're particularly interested in combining the PD-1 antibodies with antibodies or vaccines or other therapies in never smokers. Rather than giving it to them as a single agent or just the PD-1 or PD-L1 antibodies by themselves. But certainly we have seen patients with who are never smokers respond to this, so it's not a complete zero response rate. So patients can respond, it's just less often.
Great, thanks so much. It was very exciting to see that there are now trials in place that are open and accruing patients testing immunotherapy against chemotherapy for possible, if the results look good, for moving immunotherapy into the first line of treatment. Can you talk about just how, I mean, we've been here in the field for more than 60 years, and it's taken a lot of work to get to this point, and the idea of immunotherapy as a front line for a solid tumor like lung cancer really signifies that something huge is happening. What would you say to that?
I just got chills. We're very excited to be able to hopefully show that immune therapy can knock off chemotherapy for a subset of patients. But again, like I said, we've got a lot more work to do, and I just want to thank all of you who are part of those clinical trials. I think also there are trials out there combining it with chemotherapy, and I think trying to find again, how to personalize this type of therapy. There certainly will be a subset of patients who can just get single agent immunotherapy and their disease is controlled, but probably the majority of patients will still need probably some type of chemotherapy to help either the immune therapy work or get the cancer under better control or get it smaller so the immune therapy has a chance to work.
We've often heard some scientists talking about chemotherapy as a type of vaccination, meaning it goes in and it kills a number of tumor cells and releases those targets to the immune system and helps the immune system see that tumor.
Exactly. Well, we agreed that I agree that certainly could be like a vaccine, but it also can kill off some of the immune cells that our body uses to control the T cells, like we call it one subset T regulatory cells. So they regulate other T cells, and so we know that some types of chemotherapy kill those cells off. And there's also something called MDSCs that chemotherapy can affect as well. These are myeloid-derived suppressor cells, and if you kill those cells off, then it allows the T cells to remain activated as well. So chemotherapy, while it's thought to have bad effects on your immune system, it can have good effects on those cells that keep those good T cells under control.
So we've been talking about clinical trials, and that's certainly an important way for patients to get access to these types of treatments when they have not yet been FDA approved, or if they're being tested in ways for which the FDA has not approved them. At what point should a lung cancer patient consider enrolling in a clinical trial?
I believe at any point that they feel comfortable. As long as they're feeling well and able to take care of themselves, then they should be able to qualify for some type of clinical trial. Certainly standard therapy has brought us a long way, but certainly we have to work hard to improve how patients do. So depending on the patient and family's comfort, being comfortable being part of a clinical trial, patients can do this right up front, when they just initially get diagnosed. Some people decide that they want to do just standard chemotherapy first. Then they can do it in the second line treatment setting or even third line and beyond if they're feeling well. So at any time, really, I would encourage when you're feeling well, that's the best time to be a part of a clinical trial.
Yeah. Especially, all cancers are bad, but lung cancer carries certain stigmas with it. And often we hear of patients upon diagnosis either not opting for any treatment whatsoever because they've heard the horror stories of chemotherapy, or if they fail first-line chemotherapy, they don't then go on to explore second-line treatments. Do you see that happening in your clinic? And what can be done to encourage patients to continue seeking therapy?
No, I think every decision point is a personal decision to make, and certainly we support patients in whatever decision that they make. Certainly, the stigma that has been associated with lung cancer is not deserved. No one who smokes deserves to get cancer, and so I think that certainly we have to make sure that we're supportive of each patient and their family to get them through therapy. And also make sure that the people who are taking care of them, including primary care physicians, aren't nihilistic about this disease. Things are changing. And no one can tell you how you're going to do with therapy. Everybody is different. And again, if you're feeling well, there is always an option for therapy, whether it's on a trial or standard treatment. Now, if you're not feeling well and you're spending a majority of your day in bed, most likely therapies like this or even standard therapy may have too many side effects and actually may do more harm than good. And then at that point, continued supportive care and focus on symptoms is very important. But if you're feeling well, like I tell my patients, I'm going to find them option A, B, all the way to Z, so that I can try to help them run a marathon, not a sprint, so that they're alive for the next type of breakthrough that comes through.
It's true. You never know what's coming right around the corner.
Exactly.
So patients are lucky if they get to come to Sidney Kimmel Cancer Center, which is a prestigious research clinic, hospital tied to a university. A lot of the best science is there. But many patients throughout the United States get treatment at a community oncology level. So these are not academic centers. And I'm wondering if you know anything about how quickly is this new approach to treating lung cancer being adopted by the community oncologist?
I think it depends on where you live. Definitely as a patient, being informed and being able to ask about it. And if they haven't started offering immune therapy for use, is having them get you connected with a facility that does offer that sort of therapy if they believe that that's the best thing for you. Certainly my parents live in the middle of nowhere, Nebraska, and it's typical for them to drive 2 hours to get anywhere. So if transportation is available to get you to a facility that is able to offer therapy, certainly that is the best thing to do. And talking with your oncologist, they will have no problem referring you to a place that they would feel comfortable having you treated if they're not able to treat or offer you a type of therapy, and if they think that potentially would be beneficial. I would say that community oncology practices are much different than even 10 years ago. Community oncology practices do now offer quite a bit of clinical trials out there as well. And certainly, if they don't, ask them to refer you to a place that does, to at least consider some options.
That's fantastic. And unfortunately, we are out of time for today's webinar, so I can't get to all the wonderful questions that folks have been submitting. So certainly a lot of interest in your topic today, Dr. Brahmer. So in conclusion, I'd like to thank again our very generous sponsor, Regeneron, for making today's webinar possible. If you'd like to learn more about cancer immunotherapy treatment, we have a library of past webinars that we have recorded and published on the Cancer Research Institute website. And there's the URL, cancerresearch.org/webinars. Today's webinar was recorded and will be made available within a few days on that site, a few business days on that site. So please come back if you'd like to share this with someone that you think may be interested in learning about immunotherapy for lung cancer. Also, for those of you who are interested in learning about other types of immunotherapy for lung cancer, not just the checkpoint blockades that we heard quite a bit about today, we encourage you to visit our website specifically for patients and caregivers called theanswertocancer.org. It's a website focused on immunotherapy for multiple types of cancer. Lung cancer is one of those that's included there. And an important feature of this is if you're interested in looking to enroll in a clinical trial of an immunotherapy for lung cancer, we have a clinical trial finder right there on the home page. There's a phone number you can call and speak to a navigator who will help find a trial that's convenient to you and for which you may be eligible. So we strongly encourage you to check that out. And lastly, if you'd like to learn more about the mission of the Cancer Research Institute, or to learn about ways that you can get involved in supporting our mission to help us fund more research, please visit us at cancerresearch.org. Dr. Brahmer, thank you very much, and all the rest of you who came to today's webinar, thank you. I'm Brian Brewer, and I bid you well.